Hi, I'm Julie Harper. I am a dermatologist in Birmingham, Alabama, and I have spoken this week on several occasions at the American Academy of Dermatology.
Hi, I'm Johnny Akirai. I'm an associate professor at the Philip Frost Department of Dermatology at the University of Miami, and I'm also at the Miami VA. So we're going to talk about acne together.
Absolutely. So if you were going to sum up from this meeting some take-homes, maybe even one take-home from the acne sessions, what would it be?
I think what I learned from you, Julie, and from the other people in the American Acne and Rosacea Society is don't withhold treatment. Give people treatment who need it. Give it to our pregnant patients. Give it to patients who may be of a different gender identity. And finally, make sure that we don't hold treatment for isotretinoin. Get that isotretinoin going sooner. That's what I learned from you all.
How'd you know I wanted you to say that? We did not pre-plan that, and yet I think that was the take-home message. And that's a little bit of a new story.
Yeah.
It's not that we're against any certain treatments, but patients need to get to the treatment they need,
Yes.
whether it's isotretinoin or even a hormonal treatment. Get there faster.
Yes.
Get there faster, and I would say get specifically to isotretinoin faster.
Yes.
You know, and maybe even in a more mild end of the spectrum of the disease. And part of that is because we don't want acne. We need our skin to be clear, but some of it is the psychosocial part of this. Is that something that you think is important?
I think it's very important. We did a session on the psychosocial impact of acne. We know that patients who have acne are depressed, they're anxious. I have a pimple today, I'm a little anxious about that. So we know that that occurs, and we shouldn't be afraid to treat them. And for sure, we shouldn't be afraid to treat them with isotretinoin if they need it. We can work with psychiatrists, we can work with different dermatologists, but we shouldn't be afraid to treat these patients. They need to be treated.
I would echo that, and I would also, one of the articles that I presented here at the Academy this time was the relatively new meta-analysis that pools together the data that we have on depression and isotretinoin, and it was published in the JAD, but it's such good information. When you pull those studies together, it really doesn't support an increased risk of depression. In most of the studies that were included, there was a decreased risk of depression,
Yes.
or at least not a change at all. So that doesn't mean that in one individual, it may not be a problem. We still have to adequately counsel patients. But anybody who is not using isotretinoin because they're fearful of depression in everybody, we just don't have evidence to support that.
And I like a meta-analysis because it shows study after study, and it shows the safety. And we have one in our journal, but there's also one, I think, across the pond.
That's exactly right.
And the British have also supported the same type of information.
You are
that
exactly
it's
right.
safe.
That's right.
I want to ask you a question.
Okay.
And it's how do you get people to start spironolactone?
Okay.
How do you counsel them? It's for young doctors or for doctors who want to try it for the first time?
Yeah. Well, I'm a huge advocate of using spironolactone and again, maybe getting there faster. We have a tendency to think of our hormonal treatments as being alternative treatments. And maybe we're past that now. Maybe, at least in some people, these need to be moved up and thought of as more first-line agents. Not in every woman, but in some. And so when you think about doing spironolactone, I will usually look at a woman and say, we have 3 buckets or so of things that you could do. And so much of it is dependent on how aggressive she wants to be at the time. Some people don't want to take a pill.
That's true.
And so I'll say, over here we have some good topical medicines, and I think they would work well. They may take a little bit longer, but this is option 1. Option 2 here would be to do some of those same topicals and maybe a oral antibiotic for a few months. And some people like the antibiotics, and some people don't want to do an antibiotic. Option 3, and here's the part that we're keying in on here, we do have a hormonal treatment that is available. It works a little bit like a birth control pill, but it doesn't have estrogen. It's not specifically FDA approved for acne, so you might be told this is a blood pressure medicine, and in fact, at the blood pressure dose, it will lower your blood pressure. But the doses we use for acne, a blood pressure dose maybe 200 or more milligrams a day, we're going to use 25 or 50 or maybe 100. But it's an effective treatment for acne. It is something that we can certainly add for acne. And it takes a few months to kick in. There's some side effects that you need to be aware of. It can cause breast swelling and tenderness. It can cause your periods to be a little bit messed up.
Right.
I don't want you to get pregnant while you're on it. So all of those things are some things that I mentioned before we started. I usually also do take the time to call out that it's got a black box. The black box that says it was a tumorigen in chronic toxicity studies in rats. So this is in animal studies, not in women.
Gotcha.
And I even reinforce, we've got large studies now that look at the risk in women exposed to spironolactone, and they just don't show an increased risk. So I probably left something out there going through that, but I try to get through all of that information.
Boy, you did a great job.
Did I leave anything out?
No,
what did I leave out?
The only thing I would ask about labs. How do you check labs, or do you check labs?
Yeah, that's one that always comes up, and again, it's a barrier for some doctors. They're not sure. Do I need to check potassium? How often? So the lab you might check is potassium, but we had that lovely article that came out in 2015. It hit right during the Academy of that year, by the way, and I remember that because I was having to change lectures. But in that particular study, they looked at women between the ages of 18 and 45 who were healthy, who were treated with spironolactone for acne, and they compared that to a similar control group. And what they found is the hyperkalemia rate was really low, and it was the same in both of those groups. So the conclusion there was, if you're young and healthy, between 18 and 45, we don't need to be checking potassium. So I don't routinely do that.
I think what you said is awesome because of the fact that we want people to use different treatments. We don't want them to be afraid of treating acne. We want to give them the armamentarium, even if it only has 3 different buckets or pots we can put stuff in, but we can treat. And we want to treat sooner, and we want to prevent scarring. And that's how I would probably say that my feeling from this meeting is to make sure that we treat acne. We're not afraid to treat it. We get to the severe acne sooner, and we prevent scarring in these wonderful people.
Yeah, I totally agree with you on that. Now, I've heard you do some great talks, though, on antibiotics.
Okay,
I heard you do some great talks on antibiotics, and we've kind of talked about getting to isotretinoin and spironolactone and oral contraceptives. And some of that is, in some cases, jumping over antibiotics or just doing them. What do you think? What's your opinion on the antibiotics?
So my opinion on antibiotics goes along with the guidelines, but again, guidelines aren't laws. We talked about that. So I try to get people off within 3 to 4 months of a daily antibiotic regimen. Sometimes I go a little longer, and the guidelines say that. But the good thing about putting a limit is it defines expectations for the patient, so that the patient can say, you know what, in 3 months, if I'm not doing better, then maybe I'm ready to go to that stronger treatment. As far as the antibiotics, I like all the antibiotics that are out there that we can use. I use all of them. As far as monitoring, you don't have to do a lot of monitoring. As far as the concern with parents, when they come in and say, oh, should my child be on antibiotics long term? 3 months really isn't long term, and as dermatologists, we've done a great job in reducing the number of long-term prescriptions for antibiotics. We have really made an impact with this concept of antibiotic stewardship. We're doing it. We're doing less antibiotics. But with the patient sitting in front of you and you don't have a lot of options, I want people to know you can use 3 to 4 months of antibiotics, as the guidelines say, and you can go up longer if you have to, using good standard antibiotics for acne, and it's okay.
How about benzoyl peroxide?
Love it. We all use
we
it.
all love benzoyl
We all
peroxide.
love benzoyl peroxide.
Yes.
No reported documented resistance. So many different forms. You have washes, you have leave-ons, you have masks. You can use benzoyl peroxide in every way, shape, or form. Don't be afraid of it. Look for a form that works for you.
Totally agree.
Julie, thank you so much. It was such an honor to be with the immediate past president of the American Acne and Rosacea Society. I learned from her. I continue to learn from you. Thank you, and I'll see you next year.
Likewise. Thank you.
Bye-bye.